Today we are going to talk about the basics of sleep apnea and what information you need to have to be able to talk to your patient. The agenda for today is going to be talking about why do we sleep, what is sleep apnea, how does sleep apnea affect our life, what is a sleep study, how do we treat sleep apnea, and then we're going to wrap it all up. So first of all, why do we sleep? How important is sleep? So we need to sleep so that our body can repair. So basically the first thing that's important is our heart needs to rest. So our normal heart rate during the daytime can vary anywhere between 70 and 80 beats per minute, and that just depends on the person. When we sleep, that heart rate drops down to about 40 or 50 beats per minute, so about half of what it beats during the day because it is resting and repairing. Our brain also needs to rest and replenish the cells. If we don't get enough sleep and that brain does not rest, we can have problems with mood, memory, focus. The last thing that's happening when we are sleeping is our muscles. So our joints, our muscles, bruising, soreness, people recovering from surgery. Very, very important to sleep because that is when we heal. So what exactly is sleep apnea? Well, we're going to talk about that, and we're going to talk about the two types. So the definition of sleep apnea literally means without breath. The word apnea means without breath. We are not breathing. So we are going to talk about the airway. So on that right side of the left side of the diagram, we see a normal airway. So we're looking back down into the throat area. So this is our mouth and jaw. Our tongue is attached and blocks the airway. You can see over here where the obstruction is. So we're also going to talk about some nasal versus mouth breathing. So we ideally want everybody breathing through their nose. We know a lot of our patients and even ourselves may breathe through our mouth, but the important thing about nasal breathing is as the air comes in through the nose, it comes over the turbinates, which are kind of that sinus area up there. When the air passes over those turbinates, it picks up something called nitric oxide. Now, I'm not saying nitrous oxide. We're not putting our patients to sleep. Nitric oxide. And the job of nitric oxide is to bring more oxygenation to our body, more oxygen, and gives us better blood flow. We feel better. So the air passes through, picks up nitric oxide, and then heads on down back through the rest of the body. When we breathe through the mouth, if you see right here, we breathe through the mouth, the air comes in, it never goes over those turbinates. We don't get that benefit of having that nitric oxide. So we always want to encourage the nasal breathing over mouth breathing. There are some things that we can recommend for our patients. We can refer them to an ear, nose, and throat doctor. Maybe they have some blockages that need to be taken care of. Sometimes the turbinates are too large and will obstruct some breathing. The other thing for a mouth breather, if it's more of a simple case, there is something they can actually purchase on Amazon. It is called mouth tape, lip tape. So we actually gently place some taping over the lips to keep the lips sealed, which encourages the nasal breathing. So the other thing we want to look at is this back to this obstruction. So when we go to sleep and the jaw gets relaxed, our whole body relaxes, our jaw falls back. When the jaw falls back, it takes the tongue with it, getting it into the airway. So what we are doing in our offices is we are putting oral appliances into our patient's mouth at night. And what we're doing is it's going to hold that jaw in a more forward position. So it's going to mandibular advance. That's what our devices are, a MAD, mandibular advancement device. It's protruding that mandible into a more forward position, which keeps that tongue out of the airway. So we're going to talk about the two types of sleep apnea. So first there is OSA, and what that stands for is obstructive sleep apnea, which is what we are treating our patients for. So not only is the jaw falling back and the tongue is getting into the airway, the actual airway is collapsing. So if you think about your own neck and you don't have any bones in the front of your neck to hold your airway open, we hold our airway open by our muscles. When we go to sleep at night, those muscles actually get very flexible and relax. As we get older in age, those muscles are more flexible. Menopause has an effect on that. Weight has an effect on those muscles. The more fatty tissue, the more likely that airway is going to collapse. So if you think of your airway as a straw, like a big boba tea straw where we got those nice little boba balls that come through it, think of that airway during the day when we've got that boba straw, and at night it's more like a coffee stir. So try sucking some liquid through a coffee stir. It's very difficult. That's what happens to our airway. When that airway is the size of a coffee stir, it's actually snore, because we still have a little bit of an airway and things are back there vibrating and shaking, and that is snoring. When we lose that coffee stir and we don't have any breath, that is the apnea. So we know that our airway can collapse, our jaw falls back, that tongue gets in there. So there's several different things that happen with obstructive sleep apnea, that tongue in the airway. So we're actually going to talk about what an event is. When we have sleep apnea, we have so many events that happen during the nighttime. So the first thing that happens is we have that collapse or the tongue getting into the airway. So we lose our airway. First thing that happens when you stop breathing is your oxygen level will drop. Normally during the daytime, as we're sitting here breathing, we're sitting at about 98% oxygen, maybe higher, maybe slightly lower, but in the upper 90s. Oxygen levels, whenever oxygen drops below 90%, as in when we're sleeping and we start choking, our brain is going to wake up, because the brain knows without oxygen, it has about 3 minutes until it has a stroke. So the number one thing that happens with patients with sleep apnea, they're at risk for strokes. So the brain's going to wake up, know that there's a problem with the airway. It's going to send a message to our heart. So we talked earlier, our heart should be resting 40, 50 beats per minute. But that heart, because it got that message from the brain saying, hey, you better start beating real hard, real fast, get some air up here, our heart starts racing. And we can see the heart rates go up to 100, 120, 140. That's kind of like a brief jog. You're not quite running, but you are exercising in your sleep, which is not good for you, because if the heart does not rest, guess what? We're at risk for a heart attack. So the heart starts racing, and finally we take that breath. So that is an event. So the airway collapses, oxygen cuts off, brain wakes up, knows there's no oxygen, sends a message to the heart races. The other thing that happens when that heart starts racing is we start releasing hormones that we should not be releasing when we're sleeping. That is one event. Patients, it will have several events per hour. So whenever we score them, as far as what their sleep apnea score is, it is how many times is this whole cycle happening every single hour. So the other type of sleep apnea is called central. Central is a completely different animal. So it's not as common. They say about 1% of patients will have this type of sleep apnea, and it involves the brain. Basically, the brain forgets to tell the body to breathe. So unlike obstructed sleep apnea, where we have that obstruction and we can treat that with our oral appliance, we can't treat central sleep apnea. That is going to have to be a CPAP. But the other news is some patients can actually have both. They can have obstructed sleep apnea and central sleep apnea. For those patients, we can help them. We can put them into an oral appliance and get them some help. All right, so moving on, how does sleep apnea affect our life and what happens if we have it? So sleep is very important, because sleeping or not sleeping can affect our overall health. We can become very tired during the day, fatigue. There will be snoring, which affects us as well as our bed partners. Mood, memory, focus. We talked about when the brain does not relax and get enough rest and healing, we will have issues with mood, memory, focus. That includes anxiety, depression, Alzheimer's, temporary memory loss. Hypertension, because that heart's not resting and doing a lot of racing during the night, we're at risk for high blood pressure. We know we're at risk for a stroke, because if that brain is not getting oxygen, stroke is a very high probability. And again, depression, anxiety can result from this as well. So patients can also, because of sleep apnea, they can become borderline diabetic. They can have issues with GERD, that's gastroesophageal reflux disorder. We will get into the physiology of that at another time. Clenching and grinding of the teeth. When your airway is closed, you will clench and grind because you go into fight or flight mode, and you will do anything you can to open up that airway. Keep in mind, patients may not know they're doing this. They are sleeping. Even though it's disrupted sleep, a lot of times they're not aware of it. The other thing that happens if we don't sleep, we won't lose weight. Weight loss Sleep is a big component. If you don't sleep, it's just not going to happen. Again, there's physiological reasons for this, which we will get into at a later date. PCOS means polycystic ovarian syndrome. You may have patients that check that on their medical history, as well as cancer. The PCOS and cancer patients are at a higher risk for sleep apnea than patients without it. So what you are looking for in your patients. So when they're in the office and they talk about, oh, I think I snore, my spouse, my bed partner says I snore, or oh my gosh, my spouse snores, I can't stand it. Listen to those things. We might want to get those people screened. If they're tired, patients that are falling asleep out in the lobby, that's not normal. Patients that fall asleep in the hygiene chair or the dental operatory, not normal. Patients should be able to stay awake all day long. So they're very tired during the day. Looking again, the bed partners, they'll tell you everything. So if you've got a couple that comes in together and they say, oh my gosh, they snore, they'll tell you everything that happens at night. So make sure you listen. It's important information. Mallampati is a classification that we see inside the mouth. So when we have the patient open to do an oral cancer exam or intraoral examination, we're looking at the back of their throat. So when they open and just their tongue is out just a little bit, if you can see some airway back there, if you can see quite a bit of airway, that might be a 1 or a 2 Mallampati. If that tongue is really big, you don't see any airway back there, meaning the opening in the throat and the back. If you don't see anything, they're likely a class 3 or a class 4. More tissue that's in the back of the throat is going to lead to an airway issue. History of hypertension. We know that if that heart is racing, it will cause high blood pressure. We also look at BMIs. So anything over 30, BMI over 30, we would want to look at to see if there's any other symptoms with this patient. Do they have some airway issue? We also look at neck circumference. So because we talked about that airway collapse, the more weight we carry over the top of our neck, we can also carry weight on the back of our tongue. So yes, we can have a fat tongue. So when we're talking neck circumference for men, we do measure our patients' necks, and men over 17 inches would be an indicator, and for women, a measurement over 16 inches would be an indicator of a possible airway issue. We also do oral health and TMJ assessments. One thing that we look for is called scalloped tongue. So if you think of a seashell, how it's kind of scalloped and curvy at the edges, you will see that on a patient's tongue. And what those on the edges of the tongue, those little indents, those are actually imprints from the teeth. So when the patient is choking at night, suffocating, that airway is closed, and they go into that fight or flight, you'll actually start to see those images imprinted on the tongue from the fight or flight mode. We look at the color and texture of patients' tongue. Dry tongues, fissured tongues, tongues with lots of cracks in them, could be an indicator of an airway. We look at the uvula. So all the way in the back of the throat, when we tell the patient, open up and say, ah, we're looking at that uvula. So that little hangy down punchy bag thing in the back of the throat, if that is red, if it is inflamed. So the uvula, a normal uvula, you can see the whole thing. When they are snoring or have sleep apnea, it can become very elongated to the point where I've looked in the back of patient's throat and I've not been able to see the end of their uvula. It can become very fat. That's from all the vibrating and shaking that happens when they're snoring. So uvulas will tell us a lot of information. We'll notice wear on teeth. Again, they go into fight or flight, they're clenching and grinding, moving their jaw around because they're trying to open their airway, and you will see wear facets on their teeth. We look at the tonsils because tonsils are extra tissue back there, which are also clogging up that airway. So when we're overweight, we've got extra tissue. Tonsils are extra tissue. A big tongue is extra tissue. These are all possible airway issues with our patients. Erosion of the teeth from the clenching and grinding. And we're also checking out that jaw joint. The TMJ, if they're moving their jaw around in ways to open up that airway, they could possibly have some clicking, popping, crunchy noises, pain in the TMJ. We're going to talk a little bit about sleep cycles. We actually have 4. So we're going to start with the first sleep cycle is light sleep. We'll talk about deep sleep and REM sleep, and the 4th cycle is awake. So our light sleep, if you look at our graph, takes up about 50% of our sleep. So when we are in light sleep, we are able to awaken easily. We are sleeping, but we are a little bit aware of our surroundings, but it is definitely a sleep. So deep sleep, the percentages vary here. It could be anywhere from 20 to 25% of our sleep. But during our deep sleep, that's when our body is healing from the neck down. So all the cells for our muscles and tendons, our bones, all those cells are replenishing during deep sleep. So if we are interrupted during deep sleep, we might have issues with body aches, we don't heal well. REM sleep is the last one we're going to talk about. Same thing with REM, usually in the mid to upper 20s is what that percent we'd like to see that be. REM sleep is about 25% on average. It is our deepest sleep, and that's when we dream. If we are interrupted with choking and sleep apnea during REM sleep, that's when we're going to have the problems with mood, memory, and focus. That's when we can have issues with depression and anxiety. If you're not getting a good amount of REM sleep, you will have issues with that. And that is when we're healing from the neck up, so everything in our mind. One more thought on those sleep stages. The way we cycle through at night, we don't just go, okay, it's all light sleep, all deep sleep, all REM sleep. We actually go light, deep REM, light, deep REM, and that will repeat itself 3 to 4 times each night. So it's normal for a patient to hit that first REM cycle at about 90 minutes after they go to sleep. So now we're going to talk about sleep studies. We're going to talk about the 2 different types of sleep studies we have, HST and PSG, and I will tell you what that means. So first, PSG, polysomnography. This is what everyone thinks is a sleep study. When you talk sleep study to your patients, they will roll their eyes at you and say, nuh-uh, no way, I'm not going to a lab. But what it actually is, it is done in a lab. And there's lots of wires. They're not sleeping in their own bed. They've got people watching them. It's really hard to get a good night's sleep. But what we offer is called HST, and that stands for Home Sleep Test. So they do not have to go to the lab. We can let them do it in their own home. So we mail them their sleep study, so they can just wait for it to arrive in the mail, and they don't know this is an option. They're really happy to find out that it is. So in your own home, in your own bed, we get the results really fast. So as long as they take their sleep study, we will usually have the results in about maybe a day or 2. We have a doctor, a sleep doctor, a certified sleep doctor, who reads all of our tests for us and then sends those back to us. Because we are dental, we cannot diagnose sleep apnea. But sleep doctors, because they are not a dentist, cannot make an oral appliance. So we have to work together. So back to the sleep study, we'll have that sleep doctor read those results. Insurance companies will cover this, so we will bill it to their medical insurance. And it's real easy to take. So what it is, it's a watch, literally, that it just buckles onto one of your wrists. There'll be a finger sensor, so it looks like a tiny little helmet, and we just slide it over, usually one of the smaller fingers on the hand. And then one chest sensor that's either a circle or a heart goes right into the center of the sternum, gives us tons of information. So we will be able to get what's called their AHI, which is their apnea-hypopnea index. And what that means is how many times per hour do they choke or suffocate. We will get that score. We will get their oxygen. So we talked about oxygen levels earlier. We're going to see how their oxygen fluctuates all night long. Also the same with their pulse. We'll be able to see when it's low, when it's high, when it's racing. The sleep study will tell us their sleep position. Do they sleep on their right, on their left, on their back, or do they sleep on their face? It will show us snoring, and it will also show us a diagram of those sleep cycles. So how do we treat sleep apnea? There's a lot of different ways to do it. So the first one, the most common one, there's our little lady with a CPAP mask on. CPAP stands for continuous positive airway pressure. Basically, if you want to try a CPAP, you can get in your car, drive down the freeway, open the window, pop your head out the window and open your mouth. That's a CPAP. Force of air going down your throat. It works 100% of the time. There are a lot of side effects. People feel claustrophobic. The mask doesn't stay on. The mask leaks. They get eye infections from that air leaking. They can get skin infections. They can't tolerate the mask. There's a lot of problems with it. But it does work and they will breathe. And you can tell it's very sexy. We also have a surgery that we can do. It's called the UPPP. The word right below it is what UPPP stands for, and I won't even try to pronounce it. But looking at our little mouth on the bottom there, on that left side, we have a normal mouth. We see the tongue, the uvula, some pharyngeal tissue. If you look over to the right side, that's where the surgery was done, and they have removed all of that. They've taken the uvula out, the pharyngeal tissue, and trimmed all of that up to open the airway. So that is what is a Malampati 1. I've had patients that have had this done. I've actually had several patients that have had this done. And I will tell you it works until the tissue grows back. Our tissue will always grow back. So to go through all of that and end up back in the same boat is a little bit distressing. So we have something called Inspire. Inspire is a surgical implant. There are television commercials where it says, hey patient, come get Inspire because at the touch of a button your sleep apnea is gone. Well, here's how it works. So this silver box right here is a battery pack. It must be surgically implanted, much like a pacemaker on the patient, so in the upper chest. And then it has 2 wires. So the first wire goes from the battery pack to your lung. The second wire goes from the battery pack up through the tissue of your neck and attaches to the back of your tongue. So when sleep apnea is detected, what happens is that battery pack sends a electrical pulse up through that wire that goes through the neck into the tongue. It zaps the tongue, which makes the tongue push forward to get it out of the airway. And that will happen every single time it detects apnea. So keep in mind, apnea scores can be mild. They can be maybe 10 times an hour. They can be moderate, which is more like 20 times an hour. They can be severe, 30 times an hour. So imagine having this Inspire implanted into your body, and 30 times every hour you are getting zapped. Now, it works. Some patients swear by it, love it. You have to qualify to get this surgery done. You have to have a certain BMI. You have to have a certain apnea score. So just because you want it doesn't mean you can get it. We also have medications. There is a ton of television commercials right now for Zepbound. Zepbound is being marketed as, quote unquote, the sleep apnea pill. When I first heard this, it scared me and I thought, oh, there goes our career. But I looked it up, and Zepbound is a weight loss drug. So the way they're marketing this is, hey, lose your weight and that'll take care of your sleep apnea. And I will tell you they're right. So if you lose weight, it will help your sleep apnea. But sleep apnea is never cured. It is managed. It can improve. You can go from severe sleep apnea down to moderate or mild, but you won't get rid of it. If you have a crappy airway, you have a crappy airway. There are other medications such as Modafinil. That is an anti-anxiety. Patients with anxiety do not sleep well, so let's give them medication to help them sleep. Can't stay on that the rest of your life. Temazepam is a sedative. Again, sedatives are usually meant for temporary use, not permanent solutions. Finally, here is one of our oral appliances. This one happens to be a Panthera. So the way the oral appliance works, it is custom fit to our patients. We do a scan of their mouth, the digital impressions. The doctor will take that protrusive bite. So what we do, the way we figure it, is we have a little George gauge, and it's like a little slider. So we'll have the patient bite into it. The doctor will have the patient sliding their jaw forward and back. The doctor will look at how far out they can get their jaw, slid forward beyond the lower teeth, going beyond the upper teeth. And they'll usually set that appliance at about 70% of that. We never want to set our patients out as their farthest protrusion because we know we'll really hurt their jaw joint. So these appliances are adjustable. So if we set them at that 70% and we need to go a little further or we need to pull them back a little bit, we can. So totally adjustable and customizable for our patients. Very small, very comfortable, easy to take out. For some patients, we might want to make what's called an AM aligner. AM meaning morning. So we've had that oral appliance in all night, and we know that maybe our jaw is kind of in that forward position, and we want to make sure that our patients aren't walking around like bulldogs. So we will make them this AM aligner, and you can see the picture of it right here. It's made in our offices. It's just a little piece of plastic acrylic wafer. We put it in some hot water, and before we ever put them in an oral appliance, we will actually get this little wafer heated up and capture their natural bite. So, hey patient, go ahead, bite down for me. Perfect. Now I'm going to have you do the same bite on this little wafer. We have them bite into it, it sets up. Now we have a guide for their natural bite. So what we do is when they get up in the morning, they'll take out their oral appliance, okay, that they've been wearing to keep their airway open. So we know that jaw is in that forward position, and it's in that position due to the muscles, the facial muscles. So we let them take that appliance out, let those muscles relax for about 30 minutes, maybe up to an hour. Then what they'll do is they'll get their little AM aligner. It can be called a deprogrammer. It can be called a bite check, whatever they want to call it. And then they're going to put it in their mouth. Some patients might need to keep it in for 10 to 20 minutes. Other patients have told me, hey, I put that thing in, my bite's back to normal, I'm good to go. So it depends on the patient. But it helps reset the bite. Sometimes it happens naturally, sometimes it does not. We talked about that we can make them chair side. Labs can also make these for us, and they're much fancier. They look like a little mouth guard, but it's an AM aligner. They'll charge us about $100. So the thing with these is patients tend to lose them. So it's nice if we make them chair side. It's inexpensive for us to make a new one and easy for them just to pop in and have a new one made. And like I said, some patients will wear it, some won't, but it's a good idea just to make sure we don't get those bite changes. So we're going to wrap it all up here. So we can definitely help our patients. These are a couple pictures of some different appliances that we can make. There's several different kinds. The doctors will determine which appliance is best for the patient, depending upon their needs. If they have short clinical crowns, tiny little teeth, if they've got a wide mouth, if they've got tori. So the doctor will determine which appliance will be best. So what's nice about this is the treatment is very quick. Once we do the records appointment, they will have their oral appliance back from the lab in about 2 to 3 weeks. It's very effective. It does keep that airway open. So rather than the force of air that CPAP does, blowing all that tissue out of the way to open the airway, our oral appliances will stretch the airway open. So it's a nice alternative to CPAP. It's convenient for those patients that travel. They can just pop it into their carry-on bag. If you are from Nevada like I am, we have a ton of people who are outdoorsy. They hike, they camp. Good luck finding an outlet in the middle of the woods to plug your CPAP into, so they can take this with them. There's fewer side effects. We talked about all of the side effects from all the other treatments. With the oral appliance, really it's just, is their TMJ okay with it? And can we get that bite reset every morning? That's really all that we mess with. It works by taking that jaw, the lower jaw, and protruding it towards the front. Think of more like an end to end, those teeth like you're going to bite lettuce. That's usually about the position that we have those appliances made. And then we talked about the AM aligner, which that's needed, that's easy to take care of for the patient, stretching their airway rather than blowing it open via CPAP. So thank you so much. This is my information. I am Tricia Smith. I am a hygienist. My email is there. My cell phone number is there. If you ever have questions or comments or suggestions, I welcome them. You can email me, you can call me, you can text me. Thank you so much.